Tenemos una serie de pláticas muy interesantes esta tarde. El primer presentador y mi comoderador, pues yo soy su comoderador, el doctor Pradip Shetye. Él es un ortodoncista que trabaja en el Centro Craneofacial de la Universidad de Nueva York, en la ciudad en el Hospital de Nueva York. Él va a hablar sobre aspectos interesantes de ortodoncia en la adolescencia tardía. Right? You can start it. Take your time.
Good afternoon, everyone, and thanks, Dr. Figorova, for the kind introduction. I'd also like to thank all the members of the Smile Train organization and the Medical Advisory Board for having me speak at this meeting. This afternoon, I'm going to talk about orthodontic treatment during early adolescent phase. If you notice that we have not divided this program as phase 1 or phase 2 that you are usually used in general orthodontic treatment, but the treatment has been divided into phases of growth because there is sometimes delay in the eruption of teeth, and really there is no phase 1 or phase 2. Normally you treat the patient as the child grows. These are my financial disclosures. I have a book on cleft and craniofacial orthodontics recently released, and it's available on Amazon. As Dr. Figueroa said, I work at the NYU Langone Health. My position is in the Department of Plastic Surgery. I'm a full-time orthodontist. I see patients 5 days a week. 90% of my practice is taking care of patients with cleft and craniofacial anomalies, and about 10% I normally see non-cleft children. Our hospital and my office are about 10 blocks away. The Children's Hospital of NYU is on the 34th Street, and my office, as you see that second arrow, is on the 41st Street, close to the Grand Central, and we are on the 22nd floor. This is my team. Dr. Steffenberg, Dr. Flores are the two primary surgeons that do clefts, and then of course I work with other surgeons on the team doing other complex orthodontic surgery, and Margaret Lico is our speech and language therapist. I have 4 dental assistants, 3 front desk and management staff. The team has been with me for the last couple of years. So this is an office that I share with Dr. Flores and Dr. Steffenberg. Our offices are the same floor as a plastic surgery exam rooms. So many times I would bring the surgeons in the orthodontic office to see the patients together. If we're doing a pre-surgical infant orthopedics or NAM, the surgeons would come in and see the patients, see the progress, and give the inputs. And it also helps the parents to ask questions about the surgery during our orthodontic visits. This is one of the exam rooms. We have a small dental laboratory, and of course we do have cone beam CT and a 3D photograph room in our floor. And of course there is a separate photography section on another floor that does all our extraoral and intraoral photographs. So this is a timeline that you will see that we used, and I've modified that from the traditional orthodontic timeline. And the timeline goes from prenatal period. About 80% of children are seen prenatally, and then the infancy is where we do our pre-surgical infant orthopedics treatment. Preschool, our focus during this time between age 1 to 5 is speech. We try to avoid any orthodontic treatment during that time. Pre-adolescent treatment is actually preparing patients specifically for alveolar bone graft. In that time, we take care of either AP or transverse discrepancy, the transverse being maxillary expansion, the AP being the protraction headgear. But the goal here is to get bone in the cleft defect. About 50% of our patients don't need secondary alveolar bone graft because our surgeons normally perform GPP surgery, and that eliminates the need of secondary alveolar bone graft surgery. So most of our focus on those 50% patient is to correct the AP and the transverse discrepancy with a limited amount of braces. Phase 2, which is called the pre-adolescent, the early adolescent that I'm going to talk about, is actually between age 10 to 15. As I said, there's a delay in eruption of the teeth. There is no perfect time to start it. We wait for all the adult teeth to be in before we start starting treatment. Then we have the late adolescent, where the phase is actually preparing patients for orthodontic surgery. I would say 70% of our patients would need, with bilateral cleft, would need a 4-to-1 advancement, and maybe 50% of our patients with unilateral cleft would need a 4-to-1 advancement. And of course, post-adolescent patients, where the adult patients can come and see us for different timeline. So these are different phases of orthodontic treatment that we are closely involved. The red indicates the surgery. The blue indicates the orthodontic intervention. We try to limit the orthodontic intervention as much as possible, as well as reduce the duration of treatment. So PSIO is the time where we actually prepare the patients for the surgery. The next interval would be preparing patients for the bone graft. And then finally, if the patient would need or indicated for a second phase of treatment, would be post-bone graft orthodontic treatment, and then we interact with the surgeons again closely during the jaw surgery. But you can see that we do have the patient in what's called the monitoring phase, where the patient will see us on an annual basis, but there's no active orthodontic treatment going on. We have to be also careful about over-treatment. Over-treatment is a problem in a developed country. More so, it's also a problem in a developing country. It is actually a burden of care on the families, because when a family have to bring the child to the office, they miss the work. So we have to be very careful in not to over-treat these children. So the timeline or the duration of orthodontic intervention in our office that has been established in infancy, I try to finish pre-surgical infant orthopedics within the first 3 to 4 months. If we don't do anything during the preschool years, pre-adolescent, it's going to be about 6 months expansion before the bone graft. If they need a protraction headgear, we will do another round of treatment about 6 to 8 months after the bone graft. Early adolescent treatment would last anywhere between 12 to 18 months. We don't extend the treatment beyond 18 months, and I'm going to explain to you a little bit more detail. And the late adolescent treatment would be about 12 to 15 months. So there is always going to be a break. It's also good for the child to not come to the orthodontic office regularly in every month, starting 12 years till 18 years. So it's always good to give breaks to these children in between courses of treatment. During the early adolescent, that is age 10 to 15, that's the focus of my presentation, I try to group my patients into these two categories. Those patients that have orthognathic skeletal relationship, that means you have a positive A and B and a positive width analysis, that means the maxilla is forward ahead of mandible, and those patients that have mild skeletal discrepancy. And then we have the second group of patients that have moderate to severe skeletal discrepancy. The treatment for these two groups of patients is completely different, and I'm going to talk about it a little bit in more detail. You will never see the patient that has moderate to severe skeletal discrepancy getting braces on the lower arch, and I'll explain to you in a moment. So this is it's not a rigid way of classifying, but you'll see a patient with orthognathic profile. We have an A and B of greater than 2 degrees or widths of 0. Mild maxillomandibular skeletal discrepancy would be patient who have 0 to 2 degrees. And it's a good thing that we discuss this with the family. Moderate would be -5 to -1 of A and B, or -5 to -1 millimeters of width analysis. And severe, of course, anything less than -5, and width would be anything less than -5 too. So it is good to classify, because these patients would grow differently, because from the early adolescent to late adolescent, and it's important to understand the growth more than orthodontics for these patients. So what are the problems you would see in patients that have good facial profile or mild skeletal discrepancy? What type of problems you would see? you would typically see mild malocclusion, right? You'll have teeth that are rotated. And two most common problem that you would see is missing lateral incisors and possibly impacted canines or impacted any other teeth, or sometimes arch length tooth size discrepancy. The patients with cleft lip and palate have higher incidence of missing teeth, and all of you know that the lateral incisor is the most common tooth to be missing. And if the tooth is a bilateral, it could be two lateral incisors missing. That's the most common. If it's unilateral, one lateral incisor missing. And there are other teeth that could be missing, the second premolars or the maxillary mandibular that are missing. And of course, these children have a very high incidence of canine impaction. And these are numbers that I'm not going to go in detail. We know that 80% of the children have missing lateral incisors. If they are present, they are going to be small in shape and size. And once in a while, you will have supernumerary lateral incisors. So the decision would be, what do we do in case of a missing lateral incisors? So there are two treatment options, right? One option is close the space. And there are advantages and disadvantages of closing space for the missing lateral incisors. One advantage is, you have a permanent tooth in the area of the cleft. You don't need a pontic or a temporary bridge there. It maintains the alveolar bone that has been bone graft was done, and you can get a good arch. However, the disadvantage of that is the patient will need a veneer later on, but you're also making the arch a little smaller. So if you have two lateral incisors missing, you're closing all the space, you are making the arch smaller. Recent studies have shown that when you have a less number of teeth or more teeth missing, there are higher chances that the patient would need a Le Fort 1 advancement surgery. My current concept is to open space if possible, or not deliberately close the space, but if the teeth have all migrated mesially and it's sometimes challenged to distalize and it will compromise the midline, I would close the space. So let's look at this example. This is a patient with a unilateral cleft lip and palate, had NAM done in Japan, and surgery was done in New York. You can see the missing, no other intervention was done, had excellent bone. And this is the time when patient, no headgear, no at all. So when she came in, you can see that there was a missing lateral incisor, good alveolar bone. We just had a preventive lower lingual holding out to maintain the E space, because you want to use the E space as much as possible in patients that have a mild skeletal discrepancy. So what we decided was to open the space, close the space. The father was an engineer. We had back and forth discussion about whether to open or close, and the father decided we will close the space. You can see that slight midline discrepancy, but the parents were very happy with the results. And you can see that in this situation, we monitored this patient till skeletal maturity, and this relationship of the maxilla and mandible was maintained till she was 17 or 18 when we dismissed the patient. Let's talk about the options of opening the space. Again, the advantage is you're making the arch symmetrical. You can get good canine class 1 relationship, good arch forms, and you don't have to recontour the canine or the premolar. The disadvantage, you need a flipper or a temporary bridge to keep that space open till the patient is skeletally mature to get an implant placement. This is a young child that was treated at our center with, again, had NAM and had secondary alveolar bone graft early on with maxillary expansion was done, and then came for a phase 2 treatment at pre-adolescent, and we decided to open the space. So I'm going to give you a little bit of tour. So after the bone graft surgery, he underwent maxillary advancement using a protraction headgear. He wore it about 10 months, and we corrected his anterior crossbite. And then he went into a maintenance phase when he lost all his adult teeth, primary teeth. We brought him back and then bonded his upper arch only because we didn't know how he's going to grow. We opened up that space, and then you can see he was debonded. So no orthodontic treatment was done in the lower arch, only upper arch braces, and you open the space and then send him to get a a Pontic for some time, and then he had a Maryland Bridge Place. And so far, I'm going to go back. He's about 18. He has a positive overjet. There's no guarantee that he's going to maintain that correction, but he luckily has. The next important thing in this phase of treatment is a canine impaction. There is, in general population, the incidence of canine impaction is 0.8 to 5.2, but in patients with cleft lip and palate, it's about 30 to 35%. Many times in general orthodontics, we think that we open up the space, the canine is going to come through, and you'll see, I've seen so many patients that the canine sometimes doesn't descend. This is an example that I learned from that. Even if the space is open, the canine needs to be closely monitored. You can see that there was a primary canine over-retained. I removed the primary canine, and the permanent canine still did not descend down and actually went and destroyed the root of the permanent central incisor. So now for the patients that has an evidence of angulated canines, and I would go in and proactively put in gold chain and try to move them, because patients with cleft lip and palate, if the canine angulation doesn't improve, or even if there's enough space, sometimes they will not grow in where you want them to grow. In patients with moderate to severe skeletal deficiency, we don't do any camouflage treatment. We don't extract the lower premolars to camouflage it. The only time you would extract the lower premolars would be if there is a significant arch length and tooth size discrepancy. So because the patient is 11 or 12, you don't know how much growth is remaining at skeletal maturity. And then we finish the patients with an anterior crossbite and then monitor the patient for growth. The reason not to bond in the lower arch in patients with moderate to severe skeletal discrepancy, because as soon as you put braces on the lower arch, you are going to procline the lower incisors, you are going to create an increased crossbite. And there's no reason to increase the crossbite at age 11 or 12 when you're not going to operate or do the orthodontic surgical correction when the child is about 16, 17 years old. So it's very important. You will see, because the patients have a crossbite, there is going to be a deep curve of spee. And the only way you level the curve of spee is by proclining the mandibular incisors. So I see a lot of patients that come in from other places that they would put the braces on early on, and you're just going to make the crossbite worse. This is a patient with a history of bilateral cleft lip and palate. You can see she had a moderate crossbite, and we decided, we're not going to do anything in the lower arch. And you can see that we only were focusing on opening up the space for the impacted canine. And then there was a lateral incisors that we opened up the space for that and brought it down. And you finish the patient in the anterior crossbite. You cannot take this case to your American Board of Orthodontics and show your finished case. It is not finished, but it is finished for this particular condition. You end up in anterior crossbite. You wait for another 4 or 5 years till the patient is skeletally mature to do Le Fort 1 advancement surgery. This is another patient with moderate skeletal discrepancy where we decided not to intervene. This was a previous patient. We have seeing that the canine was brought down and the lateral incisor that was built, and you can see the patient was left into anterior crossbite. And then later on, the patient underwent a Le Fort 1 maxillary advancement. This is another example to show that only work on the upper arch, get your teeth in position where you want to, and then don't bond your lower teeth, because you're going to make the anterior crossbite worse, because this patient is definitely going to need a Le Fort 1 surgery at skeletal maturity. So the conclusion from this presentation is that comprehensive orthodontic treatment can be performed in patients that have orthognathic and mild skeletal discrepancy. Defer braces in the lower arch, the patient with moderate to severe skeletal discrepancy till they are skeletal mature, where you can make a definitive placement of braces on the upper arch, lower arch, and compensate it. The lateral incisor is the most common tooth to be missing, so make a decision whether you're going to close the space or open the space. Discuss with the families the benefits and risk of opening versus closing the spaces. And then monitor the path of eruption of the permanent canine, because they can cause damage to other adjacent permanent teeth. Thank you.